Hello, good evening, good afternoon, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a retired cardiac surgeon, the immediate, past president, director of Faculty of Surgical Trainers for the Royal College of Surgeons of Edinburgh, and I'm a professor in Medical Education Research and Development Unit at the University of Malaya. We're coming to you live this evening from Kuala Lumpur, thanks to IECHO and Dr. Apajita, who's doing their production based in New Delhi. If this is the first time you have joined the Black Belt Academy, welcome. And if you're returning, thank you very much indeed. We are dependent on word of mouth. We are accredited by the Royal College of Surgeons of Edinburgh and recognized by the Academy of Medicine of Malaysia. We welcome all participants at every level. I've just got the feedback from the conference that we ran at the ICOSET triennial meeting in Edinburgh. And delighted, on both days, we exceeded 60%, 5 out of 5 feedback. Now, why I only count 5 out of 5 feedback is the Disney principle, because 5 out of 5 you hardly ever give, and you give because it resonated or felt good. The comments were, amazing session. Words can't describe how inspiring and informed after the event. Incredibly useful skills to gain and apply to our practice. That's what I hope we can achieve. And I know from customer service management that any service industry that exceeds 60%, 5 out of 5 is an accolade. And I'm delighted that my colleagues and I, John Caddy, Chris Caddy, and John Taylor, received more than 60%, 5 out of 5. I'm also delighted that Dr. Apajita was able to share with you questions about this evening, and delighted to see that most of you enjoyed assisting. Only one said not at all, and another said sometimes. One candidate said they love it. So the worst experiences, and we'll ask you later on in the program, is when the surgeon themselves is anxious and is blaming everybody for their failings. Another is retracting and not being able to see the operation or too many instruments are in the way. The best experiences is when the assistant feels they're working in harmony with the surgeon and there's a mutual understanding and knowing the correct steps, being taught as you assist and being able to see clearly. The thing is, most of us start our surgical careers assisting, but I can't remember ever receiving any advice going into theatre. What is recognized is that good surgeons make good assistants, and good assistants make good surgeons. And my only advice to somebody going into theatre for the first time is one, go in with your own intended learning outcome. Know a little bit about the anatomy and ask inquiring questions appropriately of the surgeon, demonstrating your enthusiasm to learn. You see, assisting has been recognized as part of being an apprenticeship, and artisanal knowledge and craftsmanship were acquired through apprenticeships over the many years, and skills were passed down through the process of looking, doing, and learning. And I am got a computer failure here just briefly, excuse me. Okay, thank you. And it's now working better. So looking, doing, and learning. And I used to hold up a book that I received as an annual, when I'm growing up, called Look and Learn. And that applies to surgery as well, looking and learning. You see, the master in the apprentice trade demonstrated the tricks, and the apprentice learned by trial and error. Lord Bartholomew had said, surgical experience is a posy of other men's flowers, and whoever you work with will offer you some ideas or flowers that you can put into your own posy to create your own style and way of working. I trained with Ravi Pillai in Oxford, and he had an interesting way, an effective way of doing bottom hats and congrees. And it's only when I followed his rotation from the Brompton Hospital and worked with the people who trained him that I understood how he put together his method of stitching, which proves to be very effective. What is interesting about apprentices in the past, if the product was spoiled in the process by the apprentice, the guardians or parents of the apprentice were obliged to compensate the master for the loss. Expert masters were in demand, and apprenticeship training prevailed through the modern era and is still found in many parts of the world. This formed the basis of the guilds of master craftsmen, and this is an upshot of that method of learning, much celebrated and still in function today. Some of the guilds, and many of them are based in London, trace back to the 12th century. And one of the earliest charters still in existence today is the Weavers' Company from 1155. Those working in the same specialty lived near each other, and they were able, therefore, to regulate their work, maintain standards, and fix prices and resist competition. Many established their own halls and adopted their own regalia and adopted livery companies. And there are 110 livery companies in London alone. I belong to the Society of Apothecaries, and that was established in 1617 and is one of the oldest halls surviving in London near Blackfriars Bridge. The Worshipful Company of Barbers is now 713 years old. And the barber surgeons were not accredited by universities and formed into guilds of craftsmen. And that's where the apprenticeship model for barbers was instilled. In 1505, the incorporation of surgeons and barbers became the foundations of what is now known as the Royal College of Surgeons of Edinburgh, and a seal of course conferred a privilege on this group, but also mandated a knowledge of anatomy and surgical procedures. We see apprenticeships in craftsmen even today in the making of the Japanese sword or katana. It takes a lifetime to learn, and even today, a minimum apprenticeship is 5 years and unpaid. The whole process is embedded in rituals and arts that are shared by the master to the right apprentice. Very often, this is done with the apprentice just observing the work, and learning needs to be situational and is cultural and born out of respect. In management terms, Tachiono, the original CEO of Toyota, used to put aspiring managers within a circle on the shop floor of the factory. And at the end of the day, he would then ask the apprentice or the observer, what did you see during this process and what did you observe? It's interesting that Gary Kaplan, who's the CEO of the Virginia Mason Medical Center in Seattle, also takes his managers to Japan to observe the production line and to spot where the waste and the flaws are. And this is part of the Kaizen principle of learning and improving quality. Polygon Ashok, now deceased, a dear colleague, was a student at the Christian Medical Center in Vellore in India, and he tells me that training surgeons paid their masters for the privilege of being taught. That doesn't happen in surgery today. So good trainers and enthusiastic trainers really should make explicit before an operation the intended learning outcomes. Doing a whole operation, observing an operation without direction becomes a relatively meaningless exercise. And part of this partnership, standing at the table, is like having a dance partner. You can imagine if your dance partner is clumsy and is not fluid, the movements become uncomfortable and your dance partner actually ends up stepping on toes. This makes for a very uncomfortable dance, and in many respects, the same applies to surgery. And I'm sure my fellow senseis who will be joining us later will be pointing out that having an assistant who is following and in tune with what you're doing makes for a much easier operation. But there are a number of principles that are involved. So I'm going to take you over to show you some new models, and I'll be grateful if those watching, you may ask questions, but please could you keep your cameras turned off because I will not be able to see the screen and ensure that you are in focus. The first thing to say, and I'd like to introduce my son, Alistair. Alistair is third Dan cadet in karate in second Dan, and he is training with me in Niaido and Jerudu in the Japanese Center in Malaysia. He's assisted me on many of these occasions and actually added this to his CV. We had the privilege in participating in the silent mentor program on Saturday, and I asked Alistair to do the sternotomy incision, and delighted that was perfectly down the middle, all the way to the sternum and in the middle of the sternum as well. So these assisting exercises, I think, are starting to pay off. So the important thing with assisting is if we think of a dance partner, the first of all is that you'll see that Alistair is significantly taller than me. And therefore, one should adjust the table for the operating surgeon, and the assistant should either stand on the step or the surgeon should be on the step to ensure that both people are at the right functional height. I noticed that I've got some lines on my screen here. Can I just check, Dr. Aprajita, that the screen vision is okay? Can you confirm that the screen vision is okay? That's better, I think. Yeah. Excuse me, one moment. Both parties need to be of comfortable height. And for this evening, I've got heels on, Alistair is barefoot, such a we do better height. But I was working with Michael, who's 186 centimeters, and I was the first consultant ever to stand on a step to enable him to operate at a comfortable height. That is sad. The other important thing is there's the midline rule. And this is part of the dance that I described. So if I put my hand on Alistair's shoulder and he puts his hand on mine, if I move to my left, Alistair moves to his right, and our shoulders should be parallel all the time. And if I move the other side, he moves diagonally across as well. and our shoulders should be parallel all the time. In other words, there's an invisible midline or double yellow line between us that when I move, Alistair moves appropriately, such that we maximize the functional angles of our limbs and assisting. So when the surgeon moves, you move all the time. And that way, you will not be crossing your hands. The other part of crossing the hands is if that's your midline, your hand should not cross the midline either. And what's interesting in servo-gary that we are learning with the katana is that the left hand is directing the sword, but the left hand should never go across the midline. It's down that side, that side, that side, and then across the middle. The left hand never comes across the midline. And that resonated with me in surgery as well, is that your hands should never cross. So if you ever find yourself moving from one side to the other, become adept at moving the instrument from one hand to another. And that is very important. The key skill of an assistant is retraction and countertraction. And to understand that, I've come up with a little model to explain how we can practice that. So let's come over to the top, and I'll put the model on the table and swing you over the top.
What exactly is this model? What's it made of?
So what I've done is just drawn a triangle of different colors on a piece of cloth, loosely held with an elastic band over a bowl. And the reason to do this is to demonstrate some simple principles. The first principle is assisting. So Alistair is going to assist, and if I'm holding this string out, suture out, there is the needle on the end. One needs to actually hold it 2/3, 1/3. So if I'm holding it out this side, it's 2/3, 1/3, but it's important that your fingers gently hold the thread in the direction the thread is taken out. Because if you hook your finger out and the surgeon doesn't say let go, you can see it's going to pull and perhaps tear out. That is not tearing out. Whereas I have it hooked, you can see that is now tenting out. If that's in tissue, it will tear. So I'm going to pretend to stitch on some lines, and perhaps as we do this, you will follow and see what I mean. So Alice is going to hold finger and thumb in the direction of where I want to stitch, and I'm going to stitch down this blue line there. The triangle. I'm going to use the triangle, the other forceps. Okay, hold this good, and 2/3, 2/5, 3/5, and therefore no loop at the bottom. Alice is triangulating this and enables me to stitch clearly down the blue line. If I wanted to stitch down the green line, note that he's going to hold it with the other hand and move across, so it's parallel to me, and I can stitch with ease down the green line. If I change direction again, I'm going to stitch down the red line. Alistair is going to triangulate the forces, and force out that way. Okay. And that's it, that way. And I can stitch down the red line. So wherever I move, what I'm expecting from the assistant is a lateral hold on the suture and with the forceps triangulating to enable me to stitch along the line. Do that again. Let's get that triangle on. You see, when you got the triangles right, it becomes much easier for me that to take the needle through the tissue. Let's make it more awkward. I'm going to stitch down this red line, and I will be perhaps stitching backwards down this direction, and I'm holding the red line straight. Alistair is maintaining the triangle. The same principle of retraction with one forceps and a suture applies to two forceps and dissection. So let's, for example, take a blade. I am going to dissect, and Alistair, I'm going to dissect along that red line. Let's pop that out for a moment. So I would ask Alistair to hold either side of the red line, and I now triangulate, and enables me to bring my knife down the red line to make a cut. If I'm going to cut down the green line, Alistair is going to hold either side of the green line, and I can dissect down the green line. Let's pick that up again. Dissect down the green line. Yeah. If I want to dissect down the red line there, Alistair holds either side of the red line. I triangulate, I can dissect down that line. I want to dissect down that red line, Alistair holds at either side of that red line, and I can dissect down that line. Let's come to this green line again, and we triangulate. I want to dissect down that red line, triangulate. I want to dissect around this blue line. Note that Alistair's moved, I have moved, our shoulders are parallel, and I can dissect down that line. The other thing I hope you notice is that this is the operative field. My hands and my instruments are inside this field. Alice's hands are outside the operative field, and we are working like this around the operative field, ensuring that our hands do not cross and there's no overlap. Let's try that again. Following, and I'm going to stitch. So the triangle principle of assisting is either, if I'm stitching down the green line, held with the suture, and I'm holding down there, and I can stitch. If I'm stitching down the blue line, I can stitch down there. If I'm stitching down this line, you need to swap your hands over, Alistair. Pick up a triangle there, and I can just take the loop out. What I don't want to have on this side is a loop that I get caught in. So do you want to take a little bit more slack up? That's it. So there you go, you see? That all I need is that little bit on there. And I can stitch along there. If I want to stitch along the red line, and stitch along there. Dissecting, if I want to dissect along the green line there, as it holds either side, triangulating, and I can cut. I want to dissect on that red line, as it holds either side of the red line, triangulating, and I can make an incision. I want to size along this blue line here. You hold either side of the blue line. I'm triangulating, and I can cut. Red line there, and I can cut. I hope you get the message is that we're always triangulating It's either with the forceps and the suture, or both forceps, and we can move around. When I'm this way, Alice is this way. When I'm this way, Alice is this way. His hands are always on the side, remembering to hold the suture in the direction it's taken out. And as Mr. Monroe told me when I first started in cardiac surgery, it's a lateral hold and not a pull. You never reach and grab in. You never actually hook your finger around. You wait for the surgeon to hold it up. Why are we just talking about holding up the sutures? The surgeon would hold it up and pause and hold. If both ends are held up, that usually means cut or put a house stud on it. The surgeon will direct. But if both ends are held up, you need to take your scissors into the operative field, gently open them up just enough to do the job, cut and take it out. If you find your hands are wobbling like that, you're welcome to use a forceps as a fob. Take your scissors into the operative field, open them up just enough to do the job, and close. We have another little exercise we dreamt up earlier to help us with this process. And what I have in here is a whole lot of different colors of thread. And I'm just looking at the screen. I hope you can see the different colors of thread that I've got in it here. Alice has got two forceps, and I'm going to pick up a thread, and he's going to pick up either end to hold it straight. Pick up that end and that end, and hold it straight. If I pick up the yellow one, pick up either end, and hold it straight.
What do these strings represent in the anatomy?
Well, they're not representing any particular anatomy. I'm just using this as an exercise to test your skills to picking up using your forceps to hold either end. This is just an extension of the triangulation and that I was looking for earlier. So those are the principles. What does it mean in practice, and how can we actually do this? Well, tonight your surgeon is going to be Alistair, and he's going to dissect out this piece of chicken, and I am going to assist. And what I hope to demonstrate in this system are the principles that we have described. And Alistair is going to use a knife, scissors, and forceps, and I am going to direct his skills as we go. So you know how to hold the knife, Alistair. Would you like to start taking the skin off there? And note, remember, keep your blade parallel to the surface. That's it. Keep it on the skin side. Yep, very good. On the side. On this side as well. Good. Keep going. Keep it flush with that. A little bit flatter, so it's perpendicular to the edge there. Okay. And I'm holding this up, maintaining traction. So you're brushing it against the edge. All right. Keep going. And what I'm doing is I am anticipating the direction and directing Alistair's brush strokes with his knife and maintaining and triangulating the tissue and the fat so we come off here. All right. Just keep the blade flush against the surface and you're brushing it against the surface. All right. That's it, with the knife actually touching the gap there. All right. Closer on the skin, if I may demonstrate this to you, What you need to do is just take it on the gap here, right? You can be a little bit more vigorous, yeah, but keep it perpendicular. I know the camera's in the way for you there. Okay. And keep the knife.
Perhaps we could move away from the camera.
Well, underneath, and difficulty with the camera angle here. Okay, come on this side. There you go. Strike it from this side. Flatter the blade. Yeah. This one as well. Yeah, keep going. Keep going. And as the assistant, I need to maintain this tension on the skin to enable Alistair to actually develop the plane. Now that is coming beautifully. Let's come down this side to release it on this side. When you think that is not coming off very easily, then you may use scissors. All right, well done. There you go, this side. Keep it on that. Okay, use your scissors on that bit if you're finding it awkward. Use your scissors there, cut, snip through that one. Good. Keep going, cut through that lot there. Good. Good. There you go. There you go. Take your scissors and your knife and point it against that lot again.
Where should I hold with my forceps?
Well, I would just gently retract down there. Yeah. So you triangulate it. So I'm holding the two edges up here and try to triangulate it for you. Okay. That's it. I think a little bit more. And okay, you can cut through all of that. Get the scissors and cut that off. All the time, I'm anticipating or directing with the forceps and maintaining traction and counter traction. Okay, let's take that off. Gently pull with that side and maintain the traction. And each time we move along, so we triangulate it. Okay. Okay, good. And that side. Okay, right. So let's use the knife and let's cut through the muscle here in the line with the fibers, straight down in line with the fibers that direction. And the line from there down that way. See the fibers. Yeah. Okay, just gently, gently. One layer of muscle, good. There you go, excellent cut, because that's straight through that layer of muscle. Do you want to develop it up this side? A little bit, just gently, because you can see at the bottom there, we've got some vessels coming up, haven't we? Just take this off a little bit further. There we go. Okay, good. And we're coming down to some vessels here. I'm going to get the scissors and develop that plane there. You hold that one there. And I maintain the traction here. We want to just develop this plane and nibble away. And this one too, cut that. Good. Okay, that is a vascular bundle. And as if I'm assisting a trainee, I can help them with isolating these bundles, and we would otherwise tie that off. Yeah. Let's see if we can get down. This is probably, actually, we're not going to tie it off because looking at it, down to the leg, let's explore it this way. I want to start taking this muscle off. Come along this groove here on the bone.
Is my blade perpendicular?
No, you're cutting onto the bone here. Take the muscle off there. Just take this muscle off here. Okay, let's get scissors. Take it off there.
Scissors?
Yep, to cut that off there. On that, I'm trying to see if we can deflect this muscle off that bone, because we've got the femoral canal of this chicken leg, I think, is coming up there. So what we want to try and take it further, see if we can develop the plane on that side. Use your scissors, I think. But you see what I mean about you hold that one there, and I hold this here. See if you can take that off. Just careful, because that is, I think, take that off there. Okay, and oh, careful, you can see vessels coming off. You can see the vessels coming off down there. So above my forceps, you are able to cut, maybe with a knife. Again, gently cut right up against that edge. And take that little muscle off. There you go. Okay, take the scissors and dissect that out there. What I'm doing all the time in helping understand with this dissection is I'm applying traction and counter traction at each stage. I feel in many respects, take that off there. And I feel, therefore, I can help a training surgeon do an operation because I'm applying the requisite traction and counter traction at all stages of this procedure. I'll just move that around a bit and we can zoom in. And there you go, the femoral vessels. What do you reckon that is, Anderson?
Nerve.
Very good. It's white and fibrous. That's the nerve. What do you reckon that is there?
Which one?
This one here.
Well, it's pink, so vessel.
Very good. Very good. Vein or artery, do you think?
Well,
It's pink, isn't it?
vein. That's two options.
Perhaps. But it is, I'm just looking at it, it's kind of thin-walled, but it is pink. So I think maybe that is the artery. And the vein is probably darker purple. And I'm trying to look for the vein in this bundle underneath. And that's certainly the nerve, isn't it? Yeah. So with relative ease, we have applied the principles of traction and counter traction with my forceps, being able to direct, expose, probe, hold, retract, countertract, and enable Alistair to dissect out the femoral nerve, I believe that's the artery, and the femoral canal in this chicken leg with relative ease. Who said you can't train? I am confident that Alistair can hold the instruments correctly and is careful with the scissors and the knife. How did you find the assistant in traction and counter-traction there?
I was sometimes confused as to where to place my
Okay,
forceps.
yeah, all right. But on the triangle exercise, if I put it like that, where would you pick up? I'm holding there, you'd hold down there, wouldn't you, as part of the triangle? Yeah. If I'm holding there, where would you retract? You'd retract there, and therefore can use your scissors to cut into that bit, can't you? And expose that a bit further. So you can hold the tissue there, and I'm retracting, and you can separate. Don't cut too deeply, just insert and separate, insert and separate. Okay, probably cut that one. There's a vein, continue to insert and separate, insert and separate. Maybe I'll hold that out the way. Okay, there you go, well done. And good. And that really is taking it now down into the leg, isn't it? Yeah, because there's the nerve that is running now down into the chicken leg. The branch coming off down there, all the way down. So, as in the same way as we demonstrated with those triangles, if I'm holding it up like this as an assisting surgeon, you and directing you holding that, and I'm sort of indicating the area that you need to dissect. Yeah, you can see that that's a small area, therefore using a knife is probably not a good idea, but gentle dissection with a American or scissors will enable you to develop that area there. Okay, you could come in with a little bit more angle. I know the camera's a little bit awkward position as we're standing here, but you can develop that plane a bit further down there. Good. So we'd love to take questions from the audience, and I hope this has actually made sense to you, to give you some basic principles. Do you want to cut that one for me? Yeah, thank you. And see if we can separate. I'm holding here, you can hold there, this bit here, and I retract here, I've triangulated. Okay, I'm just seeing what's down in this bit. I think it's just loose areolar tissue and another small vessel passing down into the leg. Okay, well done. We got through that quite quickly, but yeah. Any questions from the audience? Any observations? I saw Sensei Keddy was present, and Prof. Sule was also a sensei, was on the line as well. But any comments or observations? Mr. Keddy is wearing different glasses. I am too.
Hi, David. Once again, masterclass, very good. In many ways, you were leading Alistair through the whole operation, simply by the way that you place the tissues and gently suggesting how he might do the cuts. I think it's important for the trainee to read up prior to the operation so they have an idea both of the anatomy of the area and what's likely to occur. And then they need to put themselves into the shoes of the surgeon and try and see where they need to go next. and it's about gently suggesting where they might like to pull in order to open up the field for the next procedure.
Indeed,
It's about developing intuition, and
indeed,
you do that based on information, and that information you do prior to the procedure.
indeed. And the best thing to do if you have not seen an operation before is go and watch it from the top end and understand the stages in the process. But there are signals that the surgeon will indeed give you, and you might be literally thrown in at the deep end. It's scary for the first time, and you're holding your breath and you're perhaps shaking and things. But there are some simple rules, and I hope these simple principles of turning with the surgeon, not crossing your hands, knowing when to swap your hands so your left hand does, the right hand doesn't pass the midline at all, and knowing how to hold a suture does go a very long way.
I think
Knowing,
the other thing is for the trainee to remain curious, and
indeed,
at the outset to establish with the trainer, do you mind if I ask questions? There will be times during an operation where it's inappropriate to ask questions, but in general, the more questions you ask, the better you understand the whole procedure.
and
Uh,
no questions too silly.
Now, there are no silly questions.
There are no silly questions at all.
Yeah.
I haven't told you my story of my best, best and worst, simultaneously best and worst assistant was assisting a pediatric cardiac surgeon do a Ross procedure. Now, I know this person didn't like me and I didn't like him, but that's beside the point. And the Ross procedure was timetabled for this particular day when his pet trainee happened to be outside the hospital. But I was the most senior trainee within the hospital, and I was asked to assist. Having previously assisted this man with an operation, and as a second assistant holding a retractor, not seeing the arm, my hand on the table, he was getting a little flustered and anxious and said, "Stop moving that retractor." And I made the fateful thing in saying, "I'm sorry, but that retractor did not move." And there's total silence in theatre as he glared at me because I dared say otherwise. So when we went into theatre, Mr. Lincoln said, "You can always tell how good a surgeon is by how they drape." And he walked in and saw me, and I could see him instantly fume. And he was glaring at the drapes, looking for something, because he is renowned to tear the drapes off if they're not appropriate. And he walked out again, so I opened up the chest and made it ready for him to proceed. Came in again, glad, could not find anything wrong, and we started the operation. It was a 5-hour operation, and during that operation, the forceps were put down on the table each time, and he'd forget where he put them. And I just passed the forceps back into his hand. I think the DeBakey forceps must have circulated from the table to my hand back into his hand over the period of 5 hours, maybe over 100, 200 times. We finished the operation. Not once did he say anything to me. He left theatre and I closed. It was the greatest compliment I've ever received that I didn't get any comment from him at all during the operation. My best and worst experience.
But in many ways, that's a generational thing.
Correct.
And also it relates, I think, partly to cardiac surgery.
Correct.
I may be displaying my own biases, but I think we all sort of elevate to the cream rises to the top. So
Correct.
we move into an area of expertise where we feel comfortable.
Correct.
But historically, there have been certain traits that are expressed by cardiac surgeons, orthopedic surgeons, and I think the trainee needs to be aware of that, but not be afraid to challenge it. It's about speaking truth to power.
Correct.
and explaining that things have moved on, and those sort of behaviors might not necessarily be the right ones for today.
Well, they're not the right
Per-
ones, and they should
Perhaps,
be
perhaps,
outlawed.
perhaps I'm talking it out of turn, but it's about being sensitive to who the trainer is and what his hopes and expectations are, and really trying to listen and get as much out of the trainer-trainee relationship.
Indeed, and that's a good point. Perhaps you even start by introducing yourself and saying, what do you expect of me? This is my experience. I don't know much. This is what I'd like to learn from the operation. What a fabulous way to start. You've already
But
started on the
you've
line
already
of
started that dialogue between you
dialogue
and
and a
your
learning contract.
Yeah.
What they expect, what you expect, what you can deliver and can't deliver. And I think that sort of clears the air, doesn't it? And invites participation. I think if you are watching an operation as a trainee and you think there's something that doesn't look quite right, do ask a question. Say, I'm a little confused. Could you explain that to me, for the anatomy? Or would you mind explaining to me what you're doing? And this can be sometimes difficult in theatre when there's a difficult procedure or tricky situation. It depends on how you see it. I do recall participating in a homograph replacement and just started at the hospital, watching a consultant do the operation. And to me, the posts had been rotated. In other words, the commissures would have occluded the coronary arteries. So as I was watching that, I actually asked the question, could you explain to me the orientation of the valve? Yes, yeah. No, and continued. And 15 minutes later, when the valve was in, the surgeon actually said, I now understand why you asked that question.
Yeah. But what's important there is that you use incisive inquiry. You ask questions rather than being judgmental.
Correct.
If you feel that something's being done wrongly, don't say, I think you're doing it wrong, sir. You just say, can you explain what's happening here, sir?
Correct.
And
I don't think, yeah. Would you use the term sir? Is that actually
well, no,
now
what I would like to do is to flatten the hierarchy and say, my name's Chris,
Yeah,
what's yours? So at the beginning, you introduce yourself, you flatten the hierarchy. So I think if you go back even before that with the WHO safety checklist, the whole idea is to flatten the hierarchy so that you have a safe environment in which to ask questions. This is
I
all
agree.
about creating psychological safety and having that crew resilience built up right from the beginning.
Indeed. And a briefing, I used to start theatre by everybody introduce themselves by their first name. If I was bringing a new trainee into theatre, I'd ask them to introduce themselves and actually to present the history of the patient. So everybody knew they knew the history of the patient and actually would also declare the trainee is going to do this part of the operation or is going to assist, and this is their level of knowledge. We did add to that, is there anything to celebrate today or anybody troubled by anything? But it was all first name terms and therefore a level playing field.
Yeah, but that's fine for you and I.
Correct.
So we've got lots of people on this call. What we need to ask them is, what is their experience of working in theatre?
Well, indeed. But there's one other important aspect to point out, is that when Alice is looking down from there onto here, look at that angle there, put your finger down at that angle. So, and I'm putting my finger down at that angle. What angle is that subtending? That's subtending 90 degrees. So to be honest, the surgeon and the assistant could be looking at the same thing, but at 90 degrees. So if you take a cylinder, on one side it will look like a cube, and the other side it looks like a cylinder. Both are correct. But the important thing is, for the surgeon, is to trust the assistant and empower them to speak up. Because put your finger there again, Alistair, in the middle. Yeah. That's 90 degrees. Straighten your arm out. That's 90 degrees. I'm looking at something totally different to what Alistair's looking at. But we're looking at the same thing. And if I am not actually asked Alistair, please, if you see something strange or different, please tell me, because I can only see 90 degrees. You're inviting problem. And that's why I think the assistant plays a valuable part, especially in coronary surgery, and you'll probably find in microsurgery this, that with the circumflex vessel at depth, and I'm stitching from deep up, if I'm putting my stitching from there down, Alistair has got the whole view of the anastomosis. I'm looking at a subtended angle. My vision, or my axis, is not as clear. And indeed, sometimes as the operating surgeon, I'd go right the other side to have the better view as well. 4 hands and 4 eyes make for a safer operation.
Indeed.
So, any comments from Prof. Seeley? Nice to see you.
Hello, Prof. Nice to see you. Hello, Prof. Prof. Chris. Yeah, I'm back to Brunei. Yeah, yeah, it was wonderful in the UK and yeah, in Edinburgh. Thank you so much. For the assisting that I was a kind of so-called a permanent assistant of my former teacher because since I was a year 2 trainees and then I been keep assisting, it's like it is the word that anticipation. We really have to anticipate the surgeon and teachers, and then and we used to say it's like reading his brain. So follow his steps and all that. Yeah. So the best part learning from him is that the anatomy. This is what we see. It's like you must know the anatomy, then only you become a good surgeon. So this is what he keeps saying. And sometimes, like if the tissues become the distorted, and you started with the simple procedures assisting, don't get boring. And later on, when you become, the regular assistant, and then you will learn more in a difficult situations. And sometimes, like he asks a questions, Sile, what I am looking for. So I answer, Prof, you are looking for ureters. He say, this correct. Yeah, that's make, it is a kind of, motivating, myself that I can read his brain, especially something like bleeding, how to stop bleedings and all that. So I think in an audience, in a participant, I saw 2 Burmese, 2 OBGYN from specialists from Myanmar, Dr. Tin Zehan and Dr. Chita. They are attending your session from Myanmar, Prof. Yangon. All right, and both of them assisted me when I was in Yangon, and then I think they will be more than happy to learn more from you as well. So thank you so much, Prof. Yeah.
Thank you, Prof. Seeley. Any comments from any others in the audience? We asked your best and worst assisting experiences. Any other comments from those who are going into theatre probably next week? Any comments? The computer is at arm's length away. I'll stand a little bit closer to see what's in the chat. I think a big round of applause for Alistair for his assisting this evening, which is excellent, and his dissection. So Okay. No other questions? Well, in which case we say thank you very much indeed. We are looking at moving the time, perhaps 2 hours to earlier, an hour and a half earlier. So it coincides with lunchtime in the UK and the morning in the USA, and perhaps not as late for the people across in Asia. I'll ask our Black Belt Academy sensei on our meeting later on this evening what they think. But I think we're probably going to move to 7:30 next week, which will be 12:30 UK time. It'll be 5 o'clock New Delhi time with Dr. Abhijita. And next week, we're going to cover the important principles of gowning and gloving. Yes, we are going to get wet. Hopefully not, but we'll be literally at the kitchen sink. So thank you very much for joining us. If this has been valuable, I'm grateful if you could fill in the feedback form. And remember, you can claim CPD points. It is accredited by the Royal College of Surgeons of Edinburgh. The other exciting news is that the shipment of instruments that I've sourced from FAS and Pakistan